Moving on to chapter 6, we're going to talk about the sympathetic nervous system and adrenergic nerve endings to start with. Adrenergic nerve endings are mainly concerned with the formation of norepinephrine. Norepinephrine travels across the space between one nerve to the smooth and cardiac muscle membrane, attaches to the adrenergic receptors, and produces a sympathetic response. Inside the nerve endings, norepinephrine may be reused if it's reuptaken or destroyed by the enzyme MAO, monoamine oxidase. Norepinephrine and epinephrine are very similar, and they both stimulate internal organs to increase sympathetic activity. Epinephrine can relax smooth muscle, but norepinephrine does not. Because of the difference in responses produced by norepinephrine and epinephrine, several different adrenergic receptor types have been identified. So alpha and beta are the two types, and each of them have two subtypes, alpha 1 and alpha 2, and beta 1 and beta 2. Alpha 1 adrenergic receptors are found predominantly on smooth muscle membranes of arteries, veins, and sphincters of the urinary and gastrointestinal tract. Alpha 2 adrenergic receptors are located in adrenergic nerve endings. Beta adrenergic receptors are found on both cardiac and smooth muscle membranes. And the predominant beta receptor in the smooth muscle of some organs and tissues is the beta 2 receptor. Okay, so drugs that affect the sympathetic nervous system are divided into sympathomimetics, which stimulate it or mimic it, and drugs that antagonize the sympathetic nervous system are called sympatholytics. So sympathomimetics are adrenergic drugs that produce effects that are similar or mimicking the sympathetic nervous system, in another word, and sympatholytics refer to adrenergic blocking drugs that antagonize or decrease sympathetic activity. Drugs including epi that stimulate the heart and cause relaxation of smooth muscle are referred to as non-selective beta-adrenergic drugs. Sympatholytic drugs that block the alpha effects of norepinephrine and epinephrine are known as alpha-adrenergic blockers. Drugs that block only beta-1 receptors are selective beta-1 adrenergic blockers, and drugs that act as adrenergic neuronal blockers. Sorry, I don't know where I'm going with that one. Sort of trailed off there. So you have blockers and you have adrenergics, and then you have alpha 1 agonists and alpha 1 antagonists as well as two. We'll get further into each type of drugs that come with those different classes. So moving on to slide 10 of chapter 6. Norepinephrine is considered to be the parent or prototype of the alpha drug class. The alpha adrenergic drugs, sorry, my slide keeps switching. The alpha adrenergic drugs have chemical structures and produce effects that are almost similar to that of norepinephrine. The most important clinical effect of the alpha adrenergic or alpha stimulating drugs is the stimulation of alpha 1 receptors that cause contraction of the smooth muscle. This includes vasoconstriction of most blood vessels, contraction of the sphincter muscles of the GI tract and urinary tracts, and contraction of the ocular muscles that causes dilation of the pupil. The adverse effects of alpha adrenergic drugs are increased blood pressure and hypertensive crisis, which can lead to hemorrhage or cardiac arrhythmias. The most common side effect of decongestant use is irritation of the nasal sinuses or eyes due to excessive dryness. So this is the class that our decongestants fall into. So on slide 11, there's a chart there with some various drugs used to either increase blood pressure or used as a nasal decongestant or an ocular decongestant. This class of drugs is sort of limited. It's really limited to somebody who is very hypotensive or somebody that is in a congested state. So moving on to beta-adrenergic drugs. So the beta-adrenergic drugs have a selective action to stimulate beta receptors. The most important action is on the heart and bronchodilation. So when you think of beta 1, that's the heart. Beta 2 is the bronchioles or the lungs. Dopamine is the neurotransmitter that acts here, and it is formed as a precursor in the synthesis of norepinephrine. When given as a drug, dopamine produces several cardiovascular effects, and it depends on whether it's low dose, medium dose, or high dose. It's really, again, if it's stimulating the heart, it's to increase blood pressure. The beta-adrenergic drugs may produce central nervous system effects, stimulation resulting in nervousness, restlessness, or tremors. The main adverse effect of the older drugs is overstimulation of the heart. Some beta-adrenergic drugs are presented on slide 13. Non-selective drugs such as dopamine, ephedrine, epinephrine, and isoproterenol. And then some selective drugs such as albuterol, dobutamine, levalbuterol, salmeterol, and terbutaline are pretty commonly used. And you can see what they're used for there. So either they are stimulating beta-1 receptors, which is heart again, or beta-2, which is the bronchioles, resulting in increased cardiac output or dilation of the bronchioles to help with asthma. So moving on to alpha-adrenergic blocking drugs. The alpha blockers compete with norepinephrine and epinephrine for binding site to the alpha-adrenergic receptors. And when it binds to the receptors, it prevents norepinephrine and epinephrine from being able to create the response. The main effect is the relaxation of smooth muscle. And alpha blockers are used in the treatment of hypertension, especially when excessive vasoconstriction is present. Side effects are similar to an increase in parasympathetic activity, constriction of the pupils, nasal congestion, increased GI activity, etc. And alpha blockers can interfere with normal cardiovascular reflexes that control blood pressure. So therefore, blood pressure decreases, and some patients may experience orthostatic hypotension and fainting when they first start therapy. So on slide 15, we have examples of alpha-adrenergic blocking drugs, and a lot of times these are used not only to treat hypertension, but also to treat benign prostatic hyperplasia, which is an enlargement of the prostate, because the prostate has alpha receptors as well. Moving on to beta-adrenergic blocking drugs. Beta-blocking drugs bind to beta-adrenergic receptors and antagonize the beta effects of epinephrine and norepinephrine. This decreases the activity of the heart, and the effect is a decrease in force of contraction, as well as eventually a decrease in blood pressure and heart rate. So beta blockers are divided into two sections: non-selective, which affects both beta-1 and beta-2, and selective beta-1 blockers. So when we talk about selective, they are selective for only the beta-1 receptors for the heart. If they start blocking beta-2, then we run into a problem with people who have asthma, which is why we want to be careful there. Slide 17 shows you some of the different selective and non-selective beta blockers and gives you an example of what they might be used for. They're used in the treatment of chest pain, hypertension, and various cardiac arrhythmias, which we've already talked about. They're also used to treat chronic heart failure. Common side effects include nausea, diarrhea, bradycardia, congestive heart failure, which it can also be used to treat, but you don't want to overdo it, and cardiac arrest. Moving on to adrenergic neuronal blocking drugs, which is a special class that we haven't really talked about yet. Drugs that interfere with the formation or storage of norepinephrine are called adrenergic neuronal blocking drugs. Therefore, the stimulation of the sympathetic nervous system is decreased. This includes methyldopa, reserpine, guanethidine, and guanidrel, and they all either prevent the storage of norepinephrine or prevent the release of norepinephrine. This usually results in a lowering of blood pressure, and these drugs are all used to lower blood pressure. So that covers chapter 6, another short chapter, and we'll be posting chapters 7 and 8 most likely Monday night. Have a great night, guys.